All right, so it's my pleasure to be back talking about pitfalls in non-cardiac POCUS. Um, Again, like I said last week, the limitations are that this is a very complex topic. And in fact, it took me quite a while to decide what I was going to talk about because there's so much to say. As POCUS is so complex and can have so many applications, so are the many ways in which one can be fooled by what they see and how they do the exam. And so again, looking at what was discussed in the previous lectures on the POCUS channel, I decided to pick some topics that, one, I feel like I'm reasonably good at, and two, that are interesting, hopefully, for the majority of people watching this. And so I'm going to talk a little bit about pitfall assessing lungs and pleura, airway and diaphragm. To be fair, mostly diaphragm, not so much airway. And then abdominal POCUS has been sort of a newish interest of mine, working in the cardiac ICU, dealing mostly with newborns, the sickest of which are the ones that are high risk of neck, as everybody knows. I sort of became more and more involved with this kind of exam and learning as I go. And so I decided to share some of my observations about abdominal POCUS, specifically looking at concerns for neck and related problems in newborns. And so starting with lung ultrasound, there have been some excellent lectures talking about this. So I decided to just pick a few examples of where we can get in trouble with the technique and potentially not really understanding what we're looking at. So this is an example of a learner trying to scan the lungs of a baby who was a little bit preterm, not intubated and moving and crying. And so one can appreciate how easy it is to sort of lose the position on the baby's chest and then have the impression that one is looking at a consolidation when in fact the probe has moved and now one actually is looking at the thymus. Another example is, this is also a NICU baby who is also active and crying. So first to note that the probe marker has been placed according to the cardiological convention and not the non-cardiac radiological convention. So that makes things a little bit more difficult. So the liver, instead of being on the right side of the image, is actually going to pop up on the left side of the image. And so as the person scans, there's this thing that pops up that looks like a consolidation. So I stopped the video to emphasize it. That is in fact the liver that just pops in and out. So again, easy to confuse. Trying to keep the probe steady on the chest, especially when it's a crying small baby, is quite challenging. And so that can be a learning curve for sure. Another example is prompted by the same problem. The baby just cries and shakes and moves. And so the learner starts with the probe oriented transversely, like you would normally do. And then because the baby moves and cries, the probe kind of slides obliquely and then ends up in the longitudinal pleural space. And so the pleura looks really funny. It makes this really funny undulating movement. So it looks a little bit maybe shaggy, maybe something. So it's easy to go kind of that sort of go sidetrack and try to interpret this abnormal pleura, which in fact is not. It's just the learner losing the appropriate position on the chest. And then the same patient, but this time scanned with a much more improved technique. So the learner is able to keep the probe relatively still on the baby's chest. You can see the baby is still crying and moving, but the learner this time is able to keep the relatively steady hand. So that is a much better picture. And then you can see how this patient, in fact, does have significant B lines, so signs of interstitial syndrome. And then interestingly, and I wanted to kind of emphasize this point, even though the classic teaching is that the B lines erase the A lines, and they do, but not completely, especially in very young kids. As they're breathing, you can actually see A lines and B lines coming in and out. So they can easily coincide in the same clip. And that doesn't mean that the B lines are not pathological. So that's kind of an interesting aspect that I've seen mostly in very young kids, specifically newborns. So that is definitely a pathological lung ultrasound, significant for interstitial edema. And in this case, it was a BPD baby, and that's what that was from. And again, important to remember that just because we see edema on ultrasound, interstitial syndrome, we cannot make a diagnosis of why it is. We can just say it's edema and then move on to try to sort out whether it's cardiac or not and what could be the reason for it. Moving on to diaphragm. I picked a couple of clips here because I thought they were really helpful and interesting to see how sometimes it can be quite easy to figure out decreased movement of the diaphragm. And so on the left side of the screen, we have this clip where you can clearly see the movement of the right diaphragm is quite decreased, whereas the movement of the left diaphragm is much more active. And this is actually an echo clip. It wasn't dedicated to a specific exam of the ultrasound, of the diaphragm. They were just looking at the position of the aorta versus IVC to establish situs. But you can clearly see the difference between right and left. This one is a little bit more involved clip. And just to make it fun, I chose one where the stomach is on the right, so it's a heterotaxy patient. But you can see the diaphragm moving pretty well on the right, and started with transverse and now it's longitudinal. And then when the radiologist moves to the left side, longitudinal left, you can see the diaphragm on the left is much more still. And so this is pretty clear, and we can be confident in the diagnosis that the left diaphragm is out. I'll let it play one more time because it's pretty cool. So again, longitudinal right diaphragm. And then it's going to move to longitudinal left diaphragm. Also note that the underlying lung here is much more collapsed, not completely maybe, but having all these kind of little air bronchograms that suggest that the lung on the left is atelectatic, which of course makes a lot of sense and supports your suspicion that the left diaphragm is not moving well. And then a little caveat here, since this talk is all about pitfalls. M-mode is frequently used to sort of quantitate a little bit the movement of the diaphragms, even though, as Dr. DeSantis was talking about in his talk, there are not really clearly established cutoffs for what's normal, what's not. But sort of doing this a while, you kind of get the idea what's close to normal and what's very decreased. But the reason I put this up here is that in this case, the patient's right diaphragm was the one that's actually okay. And so, but this baby, again, a newborn, because this is 80% of my population that I take care of, this baby had periodic breathing. So if we're not paying attention and don't take some time, at least 10, 15 seconds to watch the baby breathe and watch the M mode, we can be fooled into thinking that the diaphragm has a problem. As you can see here, it's very little movement, much better here and kind of intermediate here. So really what that is sort of the baby having these shallow breaths, interspersed with more vigorous breaths. And so we have to be careful not to call that a diaphragm problem, but just rather paying attention to the patient, realize that it's actually periodic breathing. So moving on to I'd say the meat of the talk for today. I'm going to talk about abdominal POCUS, specifically with the intent of figuring out if the patient has necrotizing enterocolitis, or in other situations where you have a very sick neonate, not really clear why they can be at a setup for neck, and you try to sort out if that's something to consider or not. There are international guidelines regarding the use of POCUS in this situation. The 2020 document that was drafted by both US and European experts endorsed using POCUS to detect signs of neck, even though they cautioned that a radiological exam is needed. And then POCUS can be a useful adjunct detecting changes consistent with neck, especially when the radiographs are not telling. And I'm going to show some examples where adding ultrasound can be quite helpful. So specifically, what you would look for with POCUS is free fluid or complex fluid, bowel wall thickness, which I think this is pretty difficult to do, especially there are not even normative values well established. That one I'm not so sure that it's good for POCUS, but pneumatosis, portal venous gas, and vascular perfusion of the gut. So these are some things that we could look for in the right setting. And then more recently in 2023, the neonatal working group put together a protocol for the crashing neonate, which I thought was excellent. And I'm kind of sad that they are ahead of the PICU/CVICU world with this. But as part of their crashing neonate POCUS protocol, they endorse looking at the abdomen for assessment of 1, effusions, and 2, signs of neck. And so this is a sort of a short description of their crashing a newborn protocol POCUS examination, where depending on your suspicion for pathology, you start either with cranial, with lung, with cardiac, or abdominal, and they also have the line-related pathology, which is not included in this figure, which could, for example, a perforated PICC line that could give you pericardial tamponade, for example, or other things like that. And so I'm curious to see how the literature will come out and show us how is this protocol performing in real life. And I wish that we in the PICU/CVICU world will come up with something similar. So talking a little bit about the normal bowel and the gut signature, and why I'm doing this is because, as you will see in the subsequent slide, it is very difficult to diagnose pneumatosis. Initially, when I started doing this, I saw pneumatosis on everyone. Everyone had weird bubble guts, and I was so concerned. And then as I learned more, I realized that I was overcalling dramatically in my mind, because I wasn't really diagnosing anything officially, but because I didn't understand this gut signature. So it doesn't really matter too much, in my opinion, what these layers are called, but what is important is to realize that the gut has this ultrasound signature, this layered appearance, like a ring in a ring in a ring, which is normal. And so once we really remember this appearance, then we can start to understand different appearance of ultrasound of the bowel in different situations. Oh, and I took this from this channel, Sonographic Tendencies. This guy is absolutely amazing. He's a pediatric ultrasonographer. I don't know where, but he is very active in social media, and his lectures are outstanding. So I highly, highly recommend looking his stuff up. So again, from one of his lecture, this is an example of normal small intestine, and this is an example of normal large intestine. And so normal bowel, what is supposed to look like? This is an example from an adult. It's using a curvilinear probe, so not a high frequency probe. And so this is why for the longest time, people said, like in the lung, you cannot really see guts, because all you see is a bunch of air and dirty shadow, and you can't really do anything. But even though, yes, that's what you see in an adult with a curvilinear probe, in kids with high frequency probes, the situation can be quite different. So here are some examples of portal air and pneumatosis. Again, this is from Sonographic Tendencies. There are some stills. And so here we notice air in the portal vein branch. Here we see air coming through in the main portal vein. That's a lot of air. And it's important to figure out whether the air that you see is in fact coming from the portal veins or from the IVC. Because if you have a line in the IVC, or actually femoral IVC, whatever it may be, or even an umbilical catheter, that can entrain little bubbles of air, and that would even can be trapped in the liver and look very concerning. And so in order to call portal venous air, you have to see that it in fact is coming from the portal system and not from the systemic venous system. And so here is an example of pneumatosis. And why I put this here is because this is crazy difficult. So if you notice this, all of this air bubbles here are actually inside the lumen. So this is not a problem. This is normal. What we call pneumatosis is actually these little dots, one here and one here. That is pneumatosis. So imagine how hard can it be to do this and be correct. I have not gotten there yet, I must admit, even though I've been doing quite a few of these. Another example of why this can be so hard. So here, and this is from an article, and I apologize, I didn't put the reference here. But you can see here that this is actually not neck. Like on the first impression, it looks like neck. There's a bunch of very bright air bubbles sort of in the gut. But when you look at it more carefully, you realize that all these air bubbles are trapped inside the bowel wall by poop. And so they look like they're air in the gut, but in fact, they're air inside the lumen of the gut. So this is not pneumatosis, but it can be quite tricky to figure that out. And then here we can see, oh, this is really bright air here. Maybe that's what it is, pneumatosis here. It's not. This is the serosa that is very echogenic. It can be echogenic, and this is, again, not pneumatosis. This is normal bowel. Another example, and this is from the article that I quoted here, actually published pretty recently in a pediatric radiology journal, that shows again how difficult it can be to figure out pneumatosis versus normal gut air. And in fact, in this baby, there were both examples. So if you look here at these yellow arrows here and here and here, this is bubbles of air. These are bubble of airs trapped in the lumen. This is a normal appearance. However, if you move a little bit to the left, these bubbles of air are actually inside the wall. So this is consistent with pneumatosis. And then you also have complex ascites, which is another sign of pneumatosis, potential perforation actually. And so combined with the clinical symptoms of the patient, this is more convincing. But I'm showing this to sort of illustrate how difficult can it be to really call pneumatosis with confidence on abdominal ultrasound. And in fact, some programs, the radiology departments choose to not even bother with these exams because they can be so difficult to sort out correctly. And actually, where I am now, the radiology department does not perform high-resolution ultrasounds to look for neck. They decided they don't want to include it in their menu, so to speak. Whereas at Riley, I used to have that option. And so that has been more of an impetus for me to start to learn. But again, it can be quite difficult, and mistakes are super, super easy to make. There are some published findings that suggest the degree of severity of neck. The high-risk findings are considered to be pneumoperitonemia, of course, being a marker of perforation, but also complex fluid or localized fluid pockets. In the intermediate category, we have absent perfusion of the gut, which I would think is higher than that, but they consider it to be intermediate, portal venous gas, pneumatosis. And then these last ones, again, to me, they're too subtle, at least at the point in my evolution of POCUS abdomen knowledge, to be able to call increased bowel echogenicity, bowel thinning or thickening or dilated. I think that's a little bit too subjective to me. And then low risk is increased perfusion, so a sign of systemic inflammation, not otherwise specified, and simple ascites. And then very, very early signs of neck can be found on ultrasound and not seen on KUB yet. And this is where I think, as a cardiac intensivist, it can be quite useful for one to be able to include that in one's differential diagnosis for badness. And the reverse is true, and this kind of goes with the general saying, better lucky than good. And so here we have an abdomen X-ray of a baby that was called perhaps pneumatosis, perhaps poop. And then that prompted the performance of an ultrasound, a high-resolution ultrasound, which interestingly did show pneumatosis, but there was only these two tiny little bubbles, so a very subtle degree of pneumatosis. And what the X-ray actually showed was these bubbly lucencies, which were actually genuinely poop. And so ultimately the correct diagnosis was made, but just because this, based on the appearance of poop on this one, an ultrasound was done, which actually showed that there was a little bit of pneumatosis and the patient got treated with antibiotics. And so I think both methods have weaknesses and strengths, and the same way as we are used to interpreting KUBs, I think it might be good if we can master the skill to become good at doing these high-resolution ultrasounds in the right setting. And so I'm going to go through a couple of cases here that I've had here at Dallas. So case one is a 6-day-old term baby with a very, very large VSG, essentially a single V physiology. And I honestly don't think that that was recognized as promptly as it should have been. So the baby was eating initially, but then as became more and more tachypnic and then started to be NG fed. And, you know, that in a single ventricle setup, that is fraught with danger. And indeed, this baby during my night on call, whereas was billed to be doing okay, developed atrial ectopic tachycardia with a heart rate of 200s. Hemodynamics were okay, so treated with amio, heart rate got better, but then lactate was still rising and the baby was not looking so well. And so I was a little bit, of course, NEC is part of the differential diagnosis, but the baby's exam was completely benign. There was no inflammation, CRP and procal were low, white count was normal. So I was a little bit, KUB was nondescript, one of those, maybe it's a little bit of distension, but nothing really. And so clearly the baby was not doing well. So I decided to do a cardiac POCUS like I do generally before intubation in sick babies, just to be sure I'm not missing very poor function or something that would alter my approach. And so I did that. And interestingly, in the subcostal, of course, I see the heart beating very fast and the function is okay, not great, but okay. And then I see these things in the liver and I wasn't even looking for that at all. And so then it dawned on me after some thought at 3 a.m. that actually is portal venous gas that I wasn't looking for. And so after I finished sort of acutely resuscitating the baby, then I took my time to do a more detailed abdominal exam. And this is what I found. And so here's the portal vein, and you can see the air bubbles literally just kind of squeezing through the portal vein. So that is what you're wanting to show to prove that this is in fact portal venous gas, the air bubbles coming through here. And of course, there's a bunch of air bubbles trapped in the liver consistent with portal venous gas. And then the other part of the question is, does the air come through the portal or come through the IVC? Because if it comes through the IVC, again, it's more likely that it's a mechanical problem from a line. And in this one, you can see there's nothing coming through the IVC. And so I continue with the rest of the exam, and then here in the left upper quadrant, you can see the bowel wall. And again, some of these bubbles of air, I'm sure it's intraluminal, but if you look all the way out to the periphery of the bowel wall, these are actually trapped inside the lumen. So that is pneumatosis. Again, in this other kind of in the pelvic area, there's another loop of bowel. And then again, some of these bubbles are inside the gut, so that is not a problem. But when you look out here, there's these bubbles that are all the way through the wall. So this is pneumatosis. But how hard is this? I mean, to be fair, once I figure out there's portal air, my suspicion increased, of course, exponentially for NEC. But if I hadn't seen that, how easy would it have been to pick up these and versus this? It takes a long time and a lot. The learning curve is very steep, but I think it's helpful. And so another thing that I've noticed is putting color on this gut is that there's very little blood flow here. There's a little bit here of like a red flicker. This area is essentially with very little blood flow, so that's very concerning. As opposed to another area of the gut in the same patient, you can see a much more reassuring pattern of blood flow. You also notice ascites here. You can see the tip of the liver kind of floating in fluid and suggestive of complex ascites, but this is not well shown, so I wouldn't call it complex just on this little shot. And then interestingly, what I see here, and to be fair, I was not confident to call it pneumoperitoneum, even though I probably should have. But you can see here what is called the gut point, where you see this gut that has like some pneumatosis on the wall, and there all of a sudden there's this transition to just a line artifact. So that has been described and the same here. You have gut here, and then it transitions to just a line. So that is the area of a small amount of perforation. And ultrasound actually has been described to be quite sensitive for it. However, because I don't feel that I'm quite competent enough, I did not really assert myself to the surgeon to say, I think this is a pneumoperitoneum. And since the abdominal x-ray was negative for it, we waited, we did conservative management. And so, however, we went for urgent PABN the next day to try to stabilize the hemodynamics because the neck was very obvious on KUBs as well. And then the patient did initially well, but then on post-op day 3, after manipulation of the abdominal drain, at my center, all newborns get abdominal drains post-op. There was fecal material coming out of the abdominal drain. And so the baby rapidly decompensated, got reintubated, and then went to the OR, where in fact it was found to have fecal spillage and got a small portion of the bowel resected and then ostomy, but recovered and ultimately went home. And so in retrospect, should I have been more forceful? I don't know. The problem is that this is so hard to be sure that the diagnosis is correct, that I think that I'm still at sort of in the ascending learning curve here. And but still, I keep wondering, was I right to not really say more about it? Another case is another newborn LGA baby, single ventricles, ductal dependent pulmonary blood flow, heterotaxia, again, just to make it fun. This baby was doing fine in room air, Prostin for pulmonary blood flow, taking PO even. In day of life 2, developed abdominal distension, was made in PO. He still looked well though, so it's very puzzling why he has this ascites. His labs again were fine, no inflammation, nothing, KUB, non-specific bowel gas. And then day of life 3, started to have more and more abdominal distension. We consulted surgery, who opined for conservative management, cultures and antibiotics. At that point, given the degree of abdominal distension, I decided to just look myself and see if I could figure out anything. And so here, on the right side, there's this massive amount of ascites. Why would this baby that looked otherwise reasonably well have this much ascites? And then the fluid is not completely anechoic. It's sort of like, for lack of a better word, it looks like a snowstorm almost, like these kind of whitish specks coming in and out, which I don't know exactly what they're from. And then again, quite a rich appearance of the ascites with complexity to it, with fibrous strands kind of connecting guts, stuff that I did not expect to see in a baby that looked otherwise quite well, because complexity of the ascites is known to be correlated with perforation. Again, a very weird appearing of kind of a frozen, like a gel-like appearance of the complex ascites on the same patient, with this weird echogenic and anechoic combination of complex fluid. And then again on this side of floating fibrinous strands. So not really making sense between how the patient looked like, what their labs looked like, and this appearance of the ascites. And so continuing on the left, And this is why I brought up the gut signature, is because look how easy it is to be confused about pneumatosis. This is actually normal gut, but it has these layers of echogenic, hypoechoic, and echogenic, hypoechoic, which is the gut signature. So there's no pneumatosis on this one. There's a bunch of fluid, but no pneumatosis. However, move your probe to the left a little bit, and this is a place where there is pneumatosis. And you can very clearly see this very localized focus of gut air trapped in the bowel wall and not inside the lumen. So I decided to just do a paracentesis because it was too weird. I couldn't figure out what was going on. And interestingly, the glucose was more than 500 on this. And so essentially we figured out that the UVC had perforated into the peritoneum, and that we were essentially giving the patient ascites by infusing fluid, which I'm not proud to say, but at least we figured it out. Interestingly, the peritoneal fluid had many white blood cells, about 50% were neutrophils, and there was no growth in this. And what does the pneumatosis got to do with this? I actually don't know. I think these were true and unrelated. I talked to the surgeon. We agreed to do 7 days of NPO antibiotics for very mild neck, and this patient did well. And so, but my point here is that complex ascites, if you look up the literature, suggest perforation. It's a sign of very high risk for perforation. But what I've been finding doing this a lot is that it's actually not specific for it. And I found a few other patients, which unfortunately I don't have their clips because I didn't take them once I moved institutions. But I did find quite maybe 4 or 5 patients, little ones, where I found complex ascites, but otherwise the patient was well. And so one has to think why that is. And so what I found in the literature is that you can have chemical peritonitis or UVC-related complications, which was our case. Liver failure is another reason. And what I found also quoted is that in utero microperforations can seal, for example, in critical CHD patients, and then when they're born, they don't actually have an active abdominal process, but you still can find the sequela of complex ascites that does not require actually anything done, and you just watch them and they get better. But it's very difficult to call it that. And so in conclusion, talking about POCUS for neck, I think this is a huge potential. It's a huge potential for both improving speed and accuracy of diagnosis, but it's also a huge potential for problems. And I understand why some people and some even radiology departments wanted to stay away from it completely. It's filled with false positives, false negatives, and then the validity of what you see. What does it actually mean? So this is a shameless plug to anyone who's interested in developing their expertise in this and want to look into this a little bit more, please reach out because I think this could be truly a game changer, especially in the NICU, CV-ICU, and newborns admitted to the PICU. So this is the end. This is the same slide I ended with for my last week. Again, POCUS does not have to be perfect to be useful, but we need to be aware of its limitations, and we need to practice, and get better and do it together.